Good morning, everyone. Thank you for taking time to watch this video. So, I'm Dr. Ritu Agarwal and I am a senior consultant in cardiac imaging at ESCC Hospital, Jaipur. And today I'm going to talk about what cardiac MR can offer, why we should be doing potentially expensive tests. So basically, what I want to talk in this video is why do potentially expensive and a lengthy test. So basically, we at ESCT Hospital have the most advanced scanners and highly trained team, which consists of a cardiac radiologist, technicians, and supporting staff. And we offer a comprehensive CMR examination, which you can see from the figure adjacent. That CMR can be used to calculate the function, mass, it can be used for perfusion studies. It gives us late gadolinium enhancement. The advanced techniques such as mapping, T1 and T2 mapping, as well as strain imaging, myocardial tagging, have added to the bunch of things we can do with CMR. So in the following slides, I'm going to take you step by step as to what in different conditions, how can CMR help. So just before beginning, I would just like to quote this paper from Vinay K. Hedge and colleagues, on which they spoke about how cardiac MR can be is a very important tool for cost saving and clinical benefits of the patient. So overall, the end results, the conclusion that they reached were 25% of the patient had a major change in the plan of care. The referral for cardiac transplant and LVAD was based on the LG characteristics of the left ventricle. The diagnosis of idiopathic heart failure was refuted, and more specific diagnosis of non-compaction and spiral cardiomyopathy were made. And the cases which were believed to be just primary pulmonary hypertension were actually found to be secondary to shunts, such as anomalous veins or AV malformation. So basically, the clinical management was completely changed for these patients based on the CMR findings. So first, let's talk about the most common group of patients, the heart failure patients, in which we have suspecting a cardiomyopathy. And although there are many ways on which we can classify cardiomyopathies, but the most common indication, most common way to do them for the treatment purposes is ischemic versus non-ischemic. Now, the role of CMR in ischemic cardiomyopathy is very well established, and we routinely do it. But the role in non-ischemic cardiomyopathy is also very important. And as we all know, the non-ischemic cardiomyopathy is actually a mixed bag, which include HCM, DCM, RCM, ARVD, non-compaction, Takotsubo, as well as peripartum and tachycardia induced. And cardiac MR actually gives very specific findings and helps us to reach a conclusive diagnosis in each of these conditions. So if we look at this slide, these are 4 patients, A, B, C, and D, hypothetically. And in each of these patients, we see some degree of left ventricular hypertrophy. There is no other specific information which is provided just looking at these pictures. So this is how essentially a patient seems when we do an echocardiogram. Now, if we add the contrast images, which is possible only by CMR to this patient, so this showing patient A showing a subendocardial to transmural scar is actually ischemic cardiomyopathy. Patient B, who had a mid-myocardial scar in the thickened septum, is a hypertrophic cardiomyopathy. Patient C, who had a diffuse subendocardial kind of scar, is cardiac amyloidosis. And patient D, who had a subepicardial and mid-myocardial discrete pattern of scar, is cardiac sarcoidosis. So we can see from the simple diagnostic of hypertrophic heart disease, we actually give each of these patients more specific diagnosis, allowing us to better manage these patients. So we have established that CMR is a diagnostic modality. Now, is that all? What else we can do with CMR? So CMR helps in risk stratification, it helps in planning of treatment, it helps in non-invasive follow-up of patients, It improves, it helps us in improve understanding of the pathophysiology of disease. It helps in reduce mortality and morbidity, and it is also a very important tool in screening of family members, such as in diseases like HCM. So we all know the role of viability in CMR. So basically, in viability, it helps us in three different ways. It gives us a scar, and it helps in many cases. We see these small areas, non-enhancing areas in the scarred myocardium, which is actually microvascular obstruction. And these are poor prognostic markers associated with increased risks of MACE in near future. And we also see this, many patients show this left apical thrombus, which again changes the management. With cardiac MR, we can draw this kind of 17 segment model for each segment, and we can know the amount of scar in each. Besides this, we have a stress cardiac MR, which can actually detect ischemia, which is the myocardium at risk, but is viable in addition to the infarcted or the scarred myocardium. So this is how a stress cardiac would look like. So we can have possible four scenarios. I borrowed this slide from this very interesting article by Perez. And so we can have on a perfusion images, there is no definite areas of hypoperfusion and there is no scar. And when we look at the cath of this patient, there is no significant arterial stenosis. Now we can have this kind of hypoperfusion, dark area in the RCA territory, but when we look at the PSIR or the post-contrast images, there is no scar. So this area is basically ischemic, but is viable. And we can see a significant stenosis in the corresponding RCA artery territory. Now, this is the third patient when we have this subendocardial ischemia in the LAD territory, but we see a scar in the corresponding territory as well. So this myocardium is dead. We see a significant stenosis and angio, but there is not much we can do in this case. There can be a possible post scenario when we have this ischemia in the LAD, and when we look at the post-contrast images, the scar is actually present in the inferior anterolateral wall, which is a different territory, a RCA territory, and not the LAD. So in this case, the RCA is scarred and dead, but the LAD is viable and ischemic. So this is, we can salvage the LAD myocardium in this patient, which is of great clinical benefit. So this offers more advantage over the traditional stress echo that we do for such kind of patients. So when we compare CMR with other modalities such as PET, because PET has been traditionally used for detection of viability, there have been multiple articles that tell us that MR is superior to PET for detection of myocardial viability. Now, one by one, I would like to just briefly tell you about the role of CMR in different cardiomyopathies. So first of all, look at this hypertrophy cardiomyopathy. So first thing, CMR will tell us whether it is really hypertrophy cardiomyopathy or it is myocardial hypertrophy due to some other cause, which can be athlete's heart. When we have this four-chamber enlargement and there is no scar, or it can be hypertensive cardiomyopathy when there is only the basal septal hypertrophy. Then there can be aortic valvular disease causing cardiac hypertrophy, and in this pattern we will see a concentric pattern of hypertrophy rather than the typical S-shaped or mid-myocardial or apical hypertrophy seen in HOOCM. And then we have all those cardiac deposit disease like Fabry's, amyloid, etc., which again have a different kind of distribution as compared to hypertrophic heart. Now, apical HOOCM is one important group in which it is very hard to see the cardiac apex on echo, and cardiac MR has a very important role which shows clearly the hypertrophy at the myocardium, and in this case there is also a thrombus sitting over the LV apex. Now, once we have established that this is hypertrophic heart, then we need to find out whether it is, if LVOT obstruction is present or not. So we classify it as hypertrophic cardiomyopathy versus hypertrophic obstructive cardiomyopathy. We can also look for the obstruction at the level of valves or in the subvalvular apparatus papillary muscle, which is very well seen on cardiac MR. And then there can be sometimes there could be a membrane or a subaortic ring, which could be causing the LVOT obstruction. And we can actually look at them also very clearly with cardiac MR. Now, the exact wall thickness is very important for prognostic purposes. And additionally, we can have the LV and the RV function, which may be abnormal if there in late cases when they will be burned out and the hypertrophy turns into dilated cardiomyopathy. Fibrosis, as I've shown in the previous case, is very important, and a percentage of fibrosis is also important because that is also one of the criteria when we decide whether we want to put a ICD or not. This cardiac MR can help us not only to see the fibrosis, but will also give us a percentage of the total mass which is scarred or fibrotic. So, in hypertrophy cardiomyopathy, it helps not only in diagnosis but also tells us about the prognosis. So, as we've seen in the previous slide, LV hypertrophy more than 30 millimeter are the patients who are at great risk of arrhythmias, and these patients benefit from early ICD therapy for prevention of SCD. And then the LG is the only non-invasive method which detects the presence of scar and which again has been proposed as a substrate for cardiac arrhythmias and heart failure. So then again we have some situations where we cannot give contrast to the patient because the patient has a bad renal function. So then comes the question, is contrast really necessary? So in this patient, as in cardiac amyloidosis, we can do the study with contrast and without contrast because we have these numbers, the native T1, the post-contrast T1 and ECV, which are abnormal whether we give a patient contrast or we do not give a contrast. So even without giving contrast, if we have these abnormal numbers, we can say the patient has cardiac amyloidosis and give useful information in patient when there is the kidney function is really bad and we cannot give contrast to the patient. So what is the role of cardiac MR in cardiac amyloidosis? So we have this because it offers a superior spatial resolution compared to echocardiography, and it gives us better estimation of the LV and the RV ejection fraction. We can do the strain imaging with CMR in a similar way we do with echo, but with much more better clarity and superior resolution. And the cine images again very useful because they helps us to tell the systolic and the diastolic dysfunction, the thickening of the mitral and the tricuspid valve, the effusion and pleural effusion, pericardial effusion. So all this will help us to confirm the diagnosis without contrast and more importantly without doing a biopsy. Then when patient comes with irregular rhythm, so there are four main possibilities of infiltrative cardiomyopathy. It could be sarcoid, it could be ARVD or with biventricular involvement, such as involving the LV as well as the RV. It can sometimes be a non-compaction and bundle branch cardiomyopathy. And each of this has different imaging appearance on cardiac MR. I just put up a few pictures here to show you the pattern of scar in amyloid is very different from ARVD. In non-compaction, we have this ratio of non-compacted to compacted myocardium and abrupt thinning of the compacted myocardium, which is important diagnostic criteria. And in a bundle branch cardiomyopathy, we do not see a scar, we just see a normal motion of the LV, interventricular septum. So based on different criteria, we can reach a specific diagnosis in this kind of patients who present with irregular rhythm. Now, that was about the myocardium. We can also use the cardiac MRI for pericardial diseases. In some cases, it's very important. So we all agree that echo is the first line modality and CT is useful only when we are looking for pericardial calcification. But CMR will give us a specific diagnosis of the type of effusion, whether it is hemorrhagic or whether it is plain bland effusion, if there is a constrictive versus restrictive physiology, and if there is acute versus calcific pericarditis. So when we have a calcified pericardium, we'll see we have a calcified pericardium and we see abnormal shift. We see a ventricular coupling, restraint and conical deformity, all of which can be seen very clearly with the CMR and no enhancement. Then we know we are dealing with calcific constrictive pericarditis. And when we have a pericardial thickening, edema and enhancement, we know we are dealing with the acute pericarditis, such as in this patient showing edema and some circumferential pericardial enhancement. And then sometimes we have edema and enhancement as well as findings of constrictive physiology. So we have acute inflammation along with constrictive physiology. And then sometimes we have edema, pericardial enhancement, but we also have edema in the myocardium and some patchy scarring, which is seen as contrast enhancement in the myocardium. So we are seeing a patient with myopericarditis. So all these patients present similarly, but on CMR we can grade them into different categories, and all of this have a major implication on the treatment of the patient. Then cardiac mass, it was very important. CMR is a main diagnostic tool for differentiating pseudotumors from thrombi, from vegetations to neoplasm. And we can see this is a thrombus of the LV apex. This is a left atrial appendage thrombus. That's a myxoma. That's a fibroelastoma. That is a rhabdomyoma in a child, and that's a metastatic tumor in a known case of lung mass. So all of this have different imaging appearance on MR and can be seen very clearly based on the different sequences that we use. Then in congenital heart disease, MR has a very important role for biventricular size and function. It also allows us to see the Q flows in all the major arteries, pulmonary, aorta, and the branch arteries. And by calculating the QPQS ratio, we can calculate if there is any residual shunt in case of repaired ESG and VSG. It can also allow us to measure differential flow in left and right pulmonary arteries. So we can know if there is any branch pulmonary artery stenosis. By quantifying the regurgitant fraction, it allows us to see the timing of the valve replacement, and complex anatomy as well as can be studied with congenital heart disease patient with CMR. So these are just a few slides of what I said. This is how we calculate the function. That is a case of LP stenosis. That is how we calculate the PR. And that is a case of RVOT aneurysm post-repair on TOF patient. So to conclude, with tissue characterization and evaluation of function, CMR actually provides us unique information for diagnosis of various cardiac diseases. And by adding the mapping techniques to CMR, we can actually understand the pathophysiology of various diseases. We are developing more faster sequences, which is bringing down the scanning time in less cooperative patients, and increase awareness and paying capacity of patients has actually improved the utilization of these techniques and will continue to improve in future. Thank you all for your patient listening.